Hello and good evening, and welcome to Smashing the Consensus, the podcast, videocast that talks to people, deals with issues that the mainstream media would largely ignore. Tonight, we do not have somebody the mainstream media ignores because she is one of the formidable figures of Irish public life, Professor Patricia Casey. Good evening.
Good evening, and Paddy, thank you very much for that slightly exaggerated introduction to my prowess. I'm very flattered, but thank you.
It is neither flattery nor exaggeration. You have appeared, I think, on more television programs than most people we know, but also you are one of the country's most distinguished psychiatrists. You are now a consultant at the Hermitage. You have produced a book called Fears, Phobias and Fantasies, which is not just intensely readable, but it is a comprehensive survey of mental health, the law on mental health and treatment in Ireland. Dr. Casey, who is the book aimed at?
The book, Paddy, is aimed at the general public. It's not a book for doctors. It's a book for the general public, people who might want to know about mental illness because they're curious. And we hear a lot of discussion now at the moment with COVID about mental health. So people's antennae are honed at the moment for mental illness. And so it's aimed at them. It's also aimed at people themselves who have mental illness, mental health problems. And thirdly, it's aimed at family members and carers, people whose lives are directly affected by psychiatric conditions within their family. And I have written the chapters that discuss the various psychiatric conditions and how to diagnose them. But I was aided in that by people who themselves suffer with mental illness and by their carers. They have contributed a large number of sections that are interspersed throughout the book. And I wanted to do that because they're a group, we often have specialists, and now at the moment with COVID, we have lots of experts talking to us. But there is nothing like hearing from the person on the ground and the person on the street who is directly affected by something. And so that was the thinking behind that element of the book. It's also got a lot of useful hints and useful websites and useful YouTube clips that people can turn to when they want help in dealing with things like panic attacks, for example. And it explains the psychiatric services, which even to me is impenetrable. If you have a mental health problem and your GP says you should really see a psychiatrist, trying to access that is, you would, I think, manage to get into Buckingham Palace or the Vatican more easily. But once you're in the system, it actually works. But to actually get there and to find out how it works is mind-bogglingly awful, even for a long-standing psychiatrist like me.
Okay, I really want to talk about so many sections of the book with you, but to start off with, you make very early on in the book, you make the point about the way the system is failing, in a sense, the way it's not resourced. We haven't enough beds.
Yes, I believe the system is failing. We have the second lowest number of inpatient beds in Europe. And there was a time when we had the highest inpatient numbers because we like locking people up, as indeed it was what happened in most countries. It wasn't a uniquely Irish thing, but people were in hospital for years and years and years, mainly because there were no treatments available. And so they didn't get better. And then that changed as treatments became available in the 1960s and the hospitals opened up. And then we moved from institutional care to units in general hospitals. That's now the prevailing approach. But in so doing, we have cut our inpatient beds. So if somebody needs acute admission, somebody who is maybe suicidal or acutely psychotic, by that I mean that they have maybe got acute schizophrenia or they're hypomanic or manic, it's very difficult to get beds for them because we have been starved of beds. And the money that was supposed to come to the psychiatric services from the closure of the institutions and the sale of the very valuable land around them has not come to psychiatry. And one of the previous ministers, James O'Reilly, admitted in public in 2013 that that money was being used to plug the holes in surgery and in some other disciplines and not in psychiatry.
The big
and
hospitals were sold off.
Say that?
If the big hospitals were sold off, the money was taken by the General Health Service. Is psychiatry, in a sense, the poor child of the health services?
It is. I mean,
yes,
it's very much the poor child, and the proportion of the overall health budget going to psychiatry now is something like 6%. It was 12 or 13% in 1980. Now in 2021 it's 6%. So it has been depleted. The other area in which we fail is the actual practice of psychiatry itself, the postcode lottery. If you're a public patient, you can only be referred to a psychiatrist that covers the geographic area that you live in. So supposing that, you know, Joe Bloggs, who lives maybe in Maharafelt, I don't know where Maharafelt is now, but say Maharafelt or someplace like that, and he needs a psychiatrist, he can only go to the psychiatrist who covers Maharafelt. And if supposing he doesn't like the psychiatrist, or supposing he wants a second opinion and doesn't feel he's getting the correct treatment, or doesn't feel, or the psychiatrist doesn't have the expertise that is needed for this man's illness, he cannot get it. He can only stay with the psychiatrist in his geographic area. So it's an extraordinarily rigid, inflexible system that I think is actually unethical and uncompassionate.
Wow, that's strong language. Unethical and uncompassionate. Is there a way around this? Is there a way of restructuring the psychiatric services to allow for a non-geographical system?
Of course there is. It's a mindset. If the legislation allowed for, in some cases, that patients may attend a psychiatrist outside their catchment area, and if that was put into practice, that should be allowed. But there is no sign of that going to happen ever, to my knowledge, and it is actually getting more inflexible. I dealt with a case recently of a lady who had been attending a particular psychiatrist in a particular practice, and the psychiatrist was actually fine, but there was a member of the team that was involved in her management who had treated her very badly in the past and had caused great angst to her, to the extent that the lady had pursued it legally, and that person was still working there, and they still wouldn't accept her in another area, even though one of the leading team members whom she had taken a case against was still around, involved in her treatment. Now that to me seems preposterous.
It seems on the face of it insane, but obviously there has to be change there. You mentioned that the book deals with the legislation, and then it moves into the area of the various mental illnesses or maladies. I was really struck by your writing on schizophrenia and the detail involved there. It does appear to be the case that the general public doesn't understand schizophrenia as an illness.
No, they don't. When you mention schizophrenia, people talk about split personality. It's the sort of the phrase that comes to mind automatically, and it has absolutely nothing to do with split personality whatsoever. It is schizophrenia is a disorder of thought processing and the interpretation of thoughts. and it's the most serious condition. It was one of the reasons why we had so many people in psychiatric hospitals in the past, because it couldn't be treated, and people with schizophrenia develop what are called negative symptoms, where they become very withdrawn, they lose interest in themselves, they don't socialize, their functioning becomes significantly impaired, and then they have very distressing symptoms like hallucinations, hearing voices when there's nobody about and thinking there's somebody about, and they'll turn their head and there's nobody there, and delusions that sometimes can lead people to harm others. But now with treatment, and it's a chronic condition, and we know from brain imaging studies that there's actually change in the brain, in the ventricles in the brain. There's actually widening of them, and so that's how we get the negative symptoms. But now with the newer treatments, people get well.
Those images are in the book.
Pardon me?
Look, those images are in the book. You included the images of the brain of
it does.
Involved.
Yes, it does. It does. I've put in some illustrations, and so for that reason, schizophrenia needs to be explained carefully to people, what it is and what it is not, and what the prognosis is. And in schizophrenia, it only affects 1% of the population, so it's not a terribly common condition, but it's the condition that causes most suffering to patients, I think, and certainly to family members. And it begins at a young age, usually in the teenage years, and then the progress used to be irreversible, but thankfully things have improved. And in this, it's also hugely important in schizophrenia that people adhere to treatment, that they take the treatments that are offered. And again, people, think, that person should really have counseling. There is no evidence whatsoever that counseling works in schizophrenia. And if they go for in-depth psychotherapy, it can actually trigger relapses. So it's a condition that needs very careful managing. There is a role for psychotherapy for some of the symptoms, particularly if the hallucinations remain chronic, but overwhelmingly the treatment is with medication, and with early intervention. If somebody is diagnosed, that they get treatment as quickly as possible, that it's not allowed to linger in the hope that they'll grow out of it.
Yes, the earlier the treatment, the earlier the treatment, the better the outcome.
Yes. Yes.
So that's a big takeaway, I think, from the things you're saying in the book. You talked about the people who wrote the patient, if you like, contributions. They're called in the book the lived experience. Yes. And these are in many cases incredibly beautifully written.
Yes.
There's some wonderful, and they lift. The book is magnificent in its scope because of that. I was really struck by the gentleman who wrote about his ADHD. It was funny, but it was also incredibly sad.
Yes.
He talked about the fact that when he was treated, when he got treatment for it, and his life improved, he envied his cohort who had always been able to do the things he could now do.
Yes, yes. ADHD is it's only recently been recognized in adults. We've known children have had it for many years. We're also conscious that it can be overdiagnosed as well, as can all psychiatric illnesses, but particularly ADHD in children is often misdiagnosed. But the recognition in adults is new. So many psychiatrists aren't very familiar with it or very confident with using the drugs that are available for it. But it's a condition that can have a terrible impact on people because it's associated with very poor concentration, losing things, and that's one sort of variety of it, where people are forgetful, they're disorganized, their concentration is poor. And the other group are the group who are very overactive and hyper all the time and banging around the place all the time. And they're two very, very different groups. But but it does interfere with people's lives significantly, and with family life, you know, because if you've got a child and who grows into an adult and is just hyper the whole time, it can be very distressing and exhausting. And similarly, the other variety, the concentrational one, that can impact on education hugely, you know, with people failing exams and regularly, whose IQ is fine when it's tested, but when you when they're trying to study, they can't focus for long enough to get the answers down on paper. And it's a hugely treatable condition. It's really a very satisfying condition to treat, and but it's difficult to get. It's difficult to get.
Must be transformative. I mean, it must transform lives.
Yes, indeed, indeed. The problem is that it's difficult to get treatment for it, because, as I've said at the beginning, a lot of psychiatrists haven't seen many adults with ADHD, and the high functioning people, you know, they say, but you look, they're at university, how can they have ADHD? But they can indeed, because they sometimes have to repeat every single year of their exams, and they eventually get there and they get a pass degree rather than an honours degree, and so on. So yeah, so ADHD is an interesting one, and the young man who wrote about it wrote extremely well about it, I thought. Yeah,
extremely well. Obviously a man who's a high achiever, incredibly intelligent, incredibly able, and this had made his life very difficult until he got treatment. Obviously, nothing about psychiatry in Ireland is complete without reference to substance abuse, alcoholism, drugs, and you're very clear on the issues there.
Yes. Yes, I mean, the issues are, there needs to be strict control, and particularly the legalization of cannabis is just a whole minefield that needs to be avoided like the plague. And I think many in psychiatry and in the profession are very concerned about the suggestion that cannabis should be decriminalized, because it can trigger psychosis, and certainly for those who have a tendency to psychosis, it can make things, or who have diagnosed psychosis, it can cause relapse. We had our own experiment a few years ago when there was a loophole in the law around certain the head shops that were around certain psychoactive substances. There were the legal highs, and I remember I was working in the Mater at the time, and the A&E was full of people with acute psychosis who had psychosis already, but it was under control, and then they'd go out for a night with their mates and say, well, this is legal, it's okay, and they would relapse. And that really generated a huge increase in workload, and a huge increase in the number of admissions for the year or so that these legal head shops were around the place. So that is why I and many of my colleagues who work in the field of substance abuse are totally opposed to cannabis decriminalization.
Yeah, I was really struck by that in the book. You said, do not believe that smoking cannabis or taking cannabis is harmless.
Indeed, indeed. And of course, people also forget that cannabis has the same carcinogens when it's smoked that cigarettes have. So we're back with the cancer issue again. And a lot of people don't realize that. They forget that.
Yes. You give advice on how people might best help substance abusers, and that was really valuable. You know, how you help a family member, how you might intervene. A lot of Irish people will at some stage have to deal with somebody who's drinking too much.
Yes, I'm not sure what the question is, Paddy.
Sorry, I was saying, can you talk us through how a person might deal with somebody who's abusing a substance?
All right.
You know, how one helps.
Well, it's very difficult, because of course people who are abusing substances either don't believe they're harmful, or you know, say, well, everybody does it kind of thing. And that's certainly the case, I think, that now with cannabis, that a lot of people in every town and village in Ireland are using cannabis. I think what we have to remember is that we have to keep emphasizing the dangers. And I think I've given some reading material. There was a book written by a man called, I think, somebody's Demons, James's Demons, I think it's called. This man, he was a foreign correspondent with the Independent in Britain, and his son began abusing cannabis and developed schizophrenia. And he Henry's Demons, and he developed schizophrenia, and he really has had a terrible time. So I think that's an important book for parents to read. I think, though, the best way to deal with it is to stop talking about decriminalizing cannabis, to talk more about the dangers of cannabis rather than the good bits of cannabis. Because they talk about medicinal cannabis, but we all know that that's just a leg up towards the full decriminalization of cannabis. So we need to talk more about the harm and less about the potential good that cannabis does. I think if there are other young people who are militantly opposed to cannabis, they need to speak up in schools, in the classrooms, for example. And parents need to be knowledgeable about the drugs and what their children may be getting up to as well, so that they can engage in a conversation about it. I think people, if they are abusing it, should be encouraged to go and talk to somebody about it. And you know, a specialist who works in the area of cannabis. They're not necessarily a doctor, but there are some very good drug addiction services around the country. And in fact, the HSE, to be fair to them, and I rarely say much good about the HSE, but they actually have some very good substance abuse counsellors all around the country. If you go into the HSE website and put in substance misuse, and then it'll give you a list of counties to select the county you're in and where you can find the substance abuse counsellors. I think you know, any person who is using drugs should consider that route.
It would be safe to say that your view is there are no safe drugs and there are no safe levels of drugs.
No, that's correct. That is exactly my view.
That's what I thought from the book. The book itself, I mean, you could spend, it is a hugely valuable resource for anybody and intensely readable. You mention in passing the difficulties. It comes up time and time again. It's not fair to say in passing. It comes up time and time again, the difficulties caused by the restrictions of COVID-19. The Friends group in Cork they're the support group for schizophrenia. They haven't been able to have a meeting in more than a year.
Yeah.
We mentioned at the start, there is no doubt that mental health has been impacted. As you said, people's antennae are waving and sensitive right now for news on this. How has COVID and restrictions impacted on individual mental health?
Well, we don't know, for the simple reason that a lot of the there aren't very many good quality studies. They're very weak sort of surveys, so they're not terribly good. We need to be careful that we don't assume that because somebody is fed up of lockdown and is really getting annoyed and distressed about it and wants it all to end and misses meeting their family, that we don't confuse that with mental illness. And I think COVID has done a disservice to the serious mental illnesses because it has reduced this very understandable distress and uncertainty that we're all experiencing to a mental illness and to a mental health problem. And it's actually a perfectly normal reaction. I have dealt with a few people who were adversely affected by COVID and by the restrictions, who did develop or who already had pre-existing mental health problems, but they worsened significantly during COVID. I think it's a moot point as to whether, for most people, COVID in itself caused any significant psychiatric illnesses. Now, except in frontline workers. And the frontline workers are a different group to folks like you and me. Now, I'm classed as a frontline worker, but you know, I'm not working in the emergency department doing swabs or anything like that. I'm seeing people who maybe haven't been tested for COVID and are. I've been asked to see them here in the hospital, for example, and you have to get gowned up when you go in to see them because they may have COVID while they're waiting for the test results. So that's as much as I would see. So it doesn't really affect me. But if you're a nurse, maybe in a nursing home and seeing elderly people dying, you're watching relatives look at their dying loved ones through a window and not being able to be there with them, you know, holding their hand or praying with them or crying with them or whatever. You know, that must be terrible for those nurses and assistant nurses and porters experiencing that. So I think they are, and the doctors, of course, as well. So they are a group that I think will inevitably suffer from depression and maybe even post-traumatic stress disorder when they're seeing people dying in a lot of distress, you know, with breathing problems and all of that. So I think they're a different group, but I think that the ordinary person on the street who hasn't had COVID and who's just utterly, completely fed up about it all and would emigrate if we could to the sun, you know, it's different. I don't think most of us have any major mental health problem.
So separate distress from actual
illness,
impact of mental illness. You
mental
make
illness
the same,
from disorder, yeah.
disorder. You make somewhat the same point about the pathologization of grief, that grief is normal. And I've heard you speak about this before.
Yes.
Are we pathologizing grief too early and too quickly? We're making grief a malady.
Yes, yes. I'm very concerned, Paddy, that when people are bereaved, they're almost within a few weeks referred for bereavement counselling. There is good evidence that grief is a process that it occurs with everybody, and it resolves for most people with the passage of time. And by resolve, I don't mean that you stop thinking about the person or crying about the person. It just means you adapt to it. You get used to it. You get used to not having the person who is gone not with you. There's also good evidence that if you offer and a person with normal grief, if they receive counselling, that it can actually impair the normal process and may make it worse. I've had a few people like that. I've had a few people like that who lost loved ones tragically, say in accidents and things like that, and were sent off to grief counsellors and then were referred on to me because it was thought they had clinical depression. And in fact, they didn't. They just needed to get away from the grief counsellor. And it wasn't that the grief counsellors were doing a bad job. They were doing what they'd been taught to do, but the people didn't need it. And the natural healing process was being interrupted. And so when you remove somebody from an intervention that isn't called for, you know, you can get positive results. And the other thing that is of concern is that people, and I had a gentleman just a couple of weeks ago who said, oh, he had been to a grief counsellor who talked him through the stages of grief, and he said they don't fit me. And I said, no, that's, a lot of people say that, and there's good evidence that the stages of grief, you know, the numbness, then the bargaining, then the anger, and all of those stages are not actually there in reality. They haven't been found to occur in people who are going through grieving process. And there's a theory that I've come across that I'm just beginning to read around called continuing bonding. By a man called Klass, who instead of talking about, you know, letting go says, it's okay to grieve. It's okay to continue to grieve, provided you're functioning. It's okay to continue to think about the loved one, and to feel sad that they're gone, and to cry at times. So I think a different approach like that is needed, and I think we have to leave it to people's own psyche to recover. Now, if people don't have supports, that's a different thing. It's important when you grieve to be able to talk about it, to to your loved ones, and to mention the person's name, and to look at the photographs. So if you can't do that, if there's nobody there who will either allow you to do it, I have one person whose children would say to her, "Oh, don't cry, you mustn't cry, you must stop crying." And her husband was only gone for a month. He'd only passed away a month earlier, and yeah. I said, no, your kids are wrong in this, tell them that I said so, they're wrong. And so if you haven't anybody to share your grief with, and to hold your hand and to cry with you, or to let you talk to them about it.
Isn't it the case we're now uncomfortable with people crying? We actually say, "Oh, they need counselling. She's still crying, and it's been more than a week since she buried her husband." Society has become uncomfortable with public displays of grief.
Yes, or any negative emotion now, and I think we're seeing it with COVID. The distress and annoyance and anger that people feel, and the being fed up. There's very little tolerance for that, and it's dressed up as it's referred to as a mental health condition, which it really isn't. And all of these are normal reactions. They're actually a sign of mental health, not mental ill health, and I think we should remember that.
So let people grieve.
Let people grieve. And if it's going on too long, of course, if it's, if the person is still not functioning after 6 or 9 months, maybe then they need an intervention. And I certainly see some people like that who, still haven't managed to get back to work. They're still, they still have a sort of a grotto to the person to the deceased person. They can't talk about them at all without crying, and they hate looking at pictures of them because they're afraid in case they lose control, and I think those people do need professional help from bereavement counsellors, and indeed sometimes they need antidepressants as well, because the grief tips into an illness, but the generality of people do not need any counselling for grief.
The vast majority of people grieve healthily.
Yes, they grieve normally. They do.
I think that's really important, because we will all experience grief. It is an absolute commonality for every human.
Yes.
We go through grief.
Yes.
And it's one of the big... Professor Casey, the book is wonderful. Thank you for being with us. I'm going to hold it up so people can see it. Now, we have some questions. Anne in Tune wants to know what she does with the close family member who doesn't appear to be delusional, but is apparently hearing voices.
Yes. Well, she should encourage the person to go and talk to the doctor about it. And if the person won't go, she might enlist the help of a trusted friend of that person. Okay. So if there's somebody that lady's relative is close to, get that person to have a chat with her and say, look, this is, maybe you should go and talk to your doctor about it. This isn't usual. It may be, it may not be, adverse in any way, but we need to get it seen to.
Okay. So I hope Anne is still with us, and here's that reply. There's another question. There's several questions, but we won't be able to go through them all. However, this is a really interesting one. I don't have a name. I just have an initial for L in Tipperary. And now what he says is, my son lies. He's 15 years old, and he does not appear to be able to tell the truth at all. I'm very worried. That's the only information I have. It sounds quite frightening for a father.
Yes, I'm loath, Paddy, to advise about a 15-year-old, because I'm not a child or adolescent psychiatrist. But again, yes. I would say a GP might refer the person to the child and adolescent mental health services, or in this case, you know, a counsellor might be of assistance. But I would have thought a doctor to see if there's any underlying issue with drugs or alcohol that's leading the young man, the teenager to tell lies. But so I think the GP is probably the best port of call.
Best port of call there. So Elle, I hope you've heard that. Professor Casey, thank you. This is the book, Fears, Phobias and Fantasies. It is an amazing survey and trove of information on mental health in Ireland, and absolutely worth reading. It's also a very beautiful book to read because you write in a wonderfully conversational way on facts.
Thanks to the assistance of my son James, who made who simplified the language where it needed to be simplified. So I have to give my son James McGuigan a clap on the back for that publicly.
So James McGuigan, thank you very much for your contribution to the book as well, and thanks to all our audience tonight, and very grateful to you, Professor Casey, again for coming on the show. Thank you very much.
It's a great pleasure.
Thank you.